Greetings. Let us talk about esophageal cancer. Here is a woman in her 50s with a long history of acid reflux and also a heavy smoker, and she also drinks alcohol quite heavily, and she came in to see us for evaluation of difficulty with her swallowing, dysphagia. She has problems with swallowing, and she says that she's been struggling to eat a hamburger because the food gets stuck, and that started a few weeks back, exactly about 4 to 6 back. And then over the last couple of weeks, she's also struggling to drink liquids. So when you see a short history spanning for a few weeks with the difficulty swallowing, especially in somebody who is at risk for cancer, then you should do an endoscopy to figure out. And when we did the endoscopy, we noticed cancer, and we're going to learn a little more about this esophageal cancer. So before we go further, let us review the normal esophageal anatomy. So when we go down with the scope, as you can see here, the esophagus is lined by a nice pink squamous lining, and the GE junction is at the normal level, and there is no hiatal hernia. And you examine the esophagus carefully, and from the squamous lining or the squamous mucosa, the squamous cell cancer develops, and it is typically seen in the eastern part of Africa and the western part of Asia, and it's also seen in anyone who smokes heavily and drinks heavily. So those are the risk factors for esophageal cancer. And in addition to squamous cell cancer, there is another type of cancer that is quite prevalent in the United States. Let us figure out what it is. So let's go back. This is a normal esophagus lined by squamous lining. The GE junction and the squamocolumnar junction are below the diaphragm, so there is no Barrett's esophagus, there is no hiatal hernia. And let us look at another patient. Here is somebody who has a hiatal hernia. We learned about it before. And then the squamous lining of the esophagus has been replaced by the beefy red columnar lining of the stomach. So this patient has Barrett's esophagus along with hiatal hernia. And patients with Barrett's esophagus are at risk for developing cancer, and that is adenocarcinoma. And this is typically seen in the Western countries, and patients who suffer with acid reflux and who also smoke heavily and who are also obese. These are the risk factors for Barrett's adenocarcinoma. So let us go and look at the endoscopy image. So when cancer develops, it may form an ulcerated mass, and as the mass grows, it tries to constrict the lumen. That's why patients have difficulty swallowing. So once you see the finding like this, the next step is the endoscopist would like to confirm the diagnosis or make the diagnosis by taking a piece of tissue from this area, otherwise known as biopsy. So when you see this, then you should be ready with your biopsy forceps so that you can take the biopsies. So in addition to biopsies, sometimes patients come to the endoscopy unit with esophageal cancer for staging. So when patients have cancer, you make a diagnosis, they go for CAT scan and a PET scan, and if there is no spread of cancer into the liver or into the lungs, and in that case you want to do further staging to figure out how deep that the cancer has gone from the lining of the esophagus deep into the esophageal wall. So let us learn about the structure of the esophagus. In the center, we have the lumen, that is the passage through which the food goes. And then the inner lining is called the mucosa. Below that, you have submucosa that contains blood vessels, connective tissue. And below that, muscle or muscularis propria. And then the outer layer is called adventitia. As you know that the esophagus is closely related to the trachea, the windpipe in the upper portion of the esophagus, and then the middle and lower portion, it is in close contact with the aorta. So these structures are important to figure out about the staging of the esophageal cancer. So as you can see here, when the cancer, as you can see the cancer on the left diagram, the cancer has penetrated the mucosa and entered the submucosa, and that is T1 cancer. When it penetrates from the submucosa into the muscle, that is muscularis propria, that is known as T2 cancer. When the cancer goes through the muscularis propria and reaches to the adventitia, then it is known as T3 cancer. When it starts involving the aorta, then it is known as T4 cancer. So you could see as the cancer goes from the mucosa to submucosa, T1, to the muscularis propria, T2, through the muscularis propria, T3, and then adjacent structures, T4. So in order to do staging, how far the cancer has gone into the wall of the esophagus, you need to go and bring a special scope that has an ultrasound at the end of the scope. So you go to the endoscope storage area and you look for the EUS scopes. And if you look at the bottom, you notice that these scopes have an ultrasound probe at the tip of the insertion tube. And there are two types of ultrasound scopes. One is called the linear scope, and the second one is called radial scope. And let us look at radial echo endoscope or radial ultrasound endoscope. So here is a radial echo endoscope or radial ultrasound endoscope. As you can see here, the plane is perpendicular, so it gives a nice cross-sectional image. And this scope cannot take any tissue. When you want to take tissue, you use the linear scope. The linear scope, the plane is parallel to the scope axis, and the needle that comes out of the scope helps you to take biopsies from the lymph nodes so that you can figure out from the ultrasound how far deep it's gone and whether the tumor has gone into the lymph nodes as well. So in summary, we learned about the lining of the esophagus from which either squamous cell cancer comes or the adenocarcinoma comes. And then we also learned about how to take a biopsy, how to establish the diagnosis by taking biopsies, and how to stage the cancer once the CAT scan and the PET scan don't show spread beyond the esophagus by doing ultrasound exam. Thank you.